A very good evening, everyone. I will, on behalf of IFReF, I welcome you all for today's CME program. Today's topic is on reducing severity of OHSs with POD aspiration in high-risk cases. We have with us Dr. Prasan Vij, who is the head of the Department of Reproductive Medicine Unit at St. Stephen's Hospital, New Delhi. We welcome you, sir. With us, we have two eminent chairpersons, Dr. Indumati Joy. Madam is a senior consultant in IVF and gynec endoscopy in Nova IVF Fertility, Anna Nagar, Chennai. Madam graduated from Keelpok Medical College in 1995. Ma'am did her DGO from Stanley Medical College in 1999 and OG from Sundara Medical Foundation in 2008. Madam has completed her fellowship in reproductive medicine in the Institute of Reproductive Medicine at M Hospital in 2011. Madam is an examiner and coordinator for the teaching and training program for the postdoctoral fellows in reproductive medicine for the Tamil Nadu Dr. MGR Medical University and the National Board, New Delhi. And Madam also has many publications to her credit. Her areas of interest are minimal stimulation protocols in IVF, male infertility, and gynec endoscopy. We welcome you, ma'am. And we also have with us Dr. Kritika Devi. She is our other chairperson. And Dr. Kritika Devi is the president of IFReF. Madam did her MBBS from Madras Medical College. She did her MD-OG from JIPMER, fellowship in andrology and reproductive medicine at Chettinad Hospital and Research Institute under two eminent teachers, Professor Pandian and Dr. Radha Pandian. Madam underwent her training program in reproductive medicine at Gleneagles Hospital, Singapore. Madam is currently a consultant in Nova IVF Fertility, Chennai. And she is also an executive committee member of IFS Tamil Nadu chapter. Madam has published research articles in international journals, and Madam has also authored the chapter titled Frozen Embryo Transfer Protocols for Handbook on Ovarian Stimulation. We welcome you, ma'am. I now request Dr. Indumati to introduce the speaker.
Yeah, thank you very much. Dr. Prasan is a renowned gynecologist and is the head of the Department of the Reproductive Medicine and Surgery in St. Stephen's Hospital in Delhi. He's done his MBBS and MD in OBG from JIPMER Pondicherry, his DNB from DNB and his DNB and his training in reproductive medicine from CMC Vellore. And Dr. Vij's clinical command over the subject and the enthusiastic teaching sessions are reflective of the range of involvement he has in his clinical and academic ventures. And Dr. Vij has abundant experience of teaching doctors for postgraduate entrance since 16 years. And he is at his best when he is speaking to the young medicos who are striving to solve the controversies in the subject. It's really nice to hear and nice to meet you, Dr. Prasan.
Thanks so much, Dr. Indumati.
Yeah, over to you.
Right, such an august gathering, and I'm privileged to speak in front of all of you, Madam President and Dr. Pandian, Indumati, and all the other speakers and the chairpersons and the people who are attending this short talk which we're having. Great to have you all, and I hope all of you are very safe wherever you are, and keep your confidence up in this testing times. So what we'll do is I'll be discussing about what we've been trying to, all of us have gone through some very exhaustive and trying moments of managing patients with ovarian hyperstimulation syndrome. And of course, we all know the etiology and we know how's the pathology of it. I'll quickly run through of what all we've been doing, what all of us have been doing, the methods by which we've been trying to reduce the severity of ovarian hyperstimulation syndrome. And of course, what we have seen has helped us in a few cases regarding the Douglas aspiration. So as we all know that, ovarian hyperstimulation syndrome, if you see, is almost 3 to 8% of, the mild and moderate type is almost 3 to 8% of all the cases of stimulations which we do for oocyte aspirations, and the highest risk patients by the experience which all of we have are those patients which are having a previous history of ovarian hyperstimulation syndrome and are having the PCOS and increased antral follicular count and high AMH. Outright basics, which all of know very well, and we've been facing this very regularly. And this, of course, is the Mathus classification, which is accepted by the Royal College regarding the classification of ovarian hyperstimulation syndrome when we group it under mild, moderate, severe, and critical category of ovarian hyperstimulation syndrome. And why I'm telling you this classification and showing you this slide is because under the moderate and the mild symptoms which we see, and these are the categories of the symptoms which we saw when we were doing this Boucher-Douglas aspiration, and the severe and the critical symptoms, like the ones which are mentioned here, like the clinical ascites, oliguria, hematocrit being very high, more than 45, and the severe category of more than 55, and the oliguria, thromboembolism, ARDS, all these symptoms which we did not see. So, of course, it's a quick revision of what we already know. And we know that sometimes we must admit these patients in the hospitals because some of these symptoms compel us to keep these patients under close supervision and surveillance. And those are the conditions where there is too much of pain and there is a lot of nausea and vomiting, when the patient is not able to keep fluids within, and worsening ovarian hyperstimulation syndrome in spite of the interventions which we keep doing on the outpatient basis, and patient cannot have a follow-up, and of course if there is severe and critical ovarian hyperstimulation syndrome. So if we also see the indications which we have for doing a paracentesis, those are the conditions where there is a severe abdominal distension and there is respiratory discomfort because of that abdominal distension. And there is also compromise to the perfusion of the kidneys because of the oliguria resulting because of the tense abdomen and the ascites. So these are the things which compel us to do a paracentesis. And as a routine, which most of us have been following, the strategies by which we've been reducing the severity of the ovarian hyperstimulation. I mean, I'm sure that most of you have seen this, and since we are working in a setup where we see a lot of IVF cases, and at least in a year, I would see something around 200 cycles, and in those, I must see ovarian hyperstimulation of the moderate type and even the severe types in at least 10 to 15% of 10 to 15 patients, not the person. So we don't do so many cycles like all of you because we don't do the third-party procedures. So for me, in a setup in Delhi, 200 procedures is a lot, and for us to have this ovarian hyperstimulation syndrome, even in the 10-15% or 10-15 patients which we have, and the moderate and the mild and the moderate types, that itself is a challenge because I would not want them to go into the severe and the critical type of ovarian hyperstimulation. So I think when we see this critical and the severe types, then we are stretched for imagination. And in spite of seeing so many cases of the severe and the critical types, we keep calling our friends sometimes that, do you have something new up your sleeves to manage these patients? And all of us agree that the agonist trigger and the antagonist protocol is the answer, more or less. But still, most of us would want to, do a fresh transfer. Most of us would want to, get more eggs and not have the risk of a luteolysis. So yes, I'm a typical long protocol guy, and even with the antagonist protocol, a lot of us do feel that, do see a lot of ovarian hyperstimulation. So that's why I see that the strategies which all of us have been seeing are still very much in use, in spite of quite a few of us shifting to the agonist trigger. So yes, the strategies which we are using are the reducing the dose of the gonadotropins and lowering the dose of the recombinant HCG, which we use for trigger. I remember the trigger was traditionally a 10,000 unit HCG, and then it became a recombinant HCG, which is Ovitrel. All of us use that, and from 500 we reduce it down to 250 micrograms, and with 250 also we get good maturation of the oocytes and we get good quality of oocytes. So reducing the dose as much as possible, using antagonist protocols with agonist trigger, like you just mentioned, and of course cancellation of the embryo transfer and freezing all embryos. Now, some of the drugs which all of us have been using, and many of us have been discussing about this on various forums, are the use of albumin and use of starch. Of course, starch, not many people are very happy because of the side effects. But yes, albumin, even sometimes we give 8-hourly albumin when the patients are having too many oocytes. And when the patient is getting into a severe mode, then I have given albumin even twice or thrice in a day, and we've have patients whom we've been able to save. And of course, gabagolin's role in reducing the vascular endothelial growth factor is well known, and using letrozole as an anti-estrogen drug. And of course, my favorite these days is to use an antagonist injection after the aspiration when we have more than 20 eggs, to give the antagonist injections to reduce the estradiol. So these are the general tricks up our sleeves, and most of us have been using them. But then what I have seen recently is that if we start thinking about aspirating the pouch of Douglas, then when we are doing these aspirations, when there are something like 20 to 30 follicles which we have aspirated, all of us see that the number of punches, you can reduce the number of times you go through the vaginal fornix, but you cannot reduce the punches onto the ovarian follicles, because when we go through one prick also, eventually the number of punches to the follicles will be equal to the number of the eggs which are present, number of follicles which are present. So those will seep and those will leak their fluids into the pouch of Douglas. And we know these are very rich in proteins and in the vascular endothelial growth factor. And then these are having a lot of pro-angiogenic factors like the interleukin 2, interleukin 6, interleukin 8. Of course, interleukin 6 is something which we gynecologists would try to remember, but now interleukin 6 is common knowledge across the world because of the current COVID crisis which we are facing. But yes, these have been the mediators which are the ones which irritate the endothelial surfaces. They irritate the peritoneal surfaces, and it starts pulling in the fluids into the peritoneal cavity, and of course also in the various other third space collections like in the pleural effusion, even pericardial effusion. All of you must have seen some severe cases with them. So these are because of the the increased oncotic pressure of the fluids which are there in the pouch of Douglas, and they will pull in the fluids and add into the burden into the abdomen. And that what we've seen is that if you start aspirating at the end of the procedure, that is, once you've done the complete aspiration of the follicles, invariably there'll be around 50 to 100 ml of fluids in the pouch of Douglas. And I would mostly leave this because we know it is blood, and that blood get absorbed into the body, and it does not cause much harm to the patient. That's what we always thought. But then off late we decided that we know that these fluids, as early as 1997, there was a paper by Ritz and Abulgar which said that these fluids, the ones which are in the pouch of Douglas, they are rich in the vascular endothelial growth factors and also in the interleukins. These are the ones which can be the cause of, obviously, the initiation of the syndrome which we see. So why not aspirate this pouch of Douglas and reduce the burden from the first day itself? So we tried it as a lark. I just thought that maybe let's just empty the pouch and let's see what happens. And this fluid which is there in the pouch also was a trigger for a lot of post-operative pain. That was the initial thought behind doing this aspiration of the pouch of Douglas, because this fluid is actually irritating the pouch of Douglas, and it is causing a patient to have a lot of tenesmus, a lot of pressure in the pouch, and the patient would feel like voiding repeatedly in the immediate post-op period and having a sense of defecating. So that bladder tenesmus, rectal tenesmus, all of this would be the presentation. So I decided that maybe reduce this irritating blood from the pouch of Douglas. So that was the initial thought behind doing this aspiration from the pouch of Douglas. And it was basically, to be very frank, it was not the idea of reducing the severity of OHSs, because when we started doing IVF, I started doing it way back in 2002, 2003, and that time it would be just good that we could do the aspirations and take the eggs and get a good quality embryo and have an implantation, and we were very happy with the 25% rate of success that time. So of course, reducing the post-op complication was something on my mind more than anything else. But then I saw that once I did this, that 4-5 of my patients, the ones which were at high risk, they were all PCOS and they were all having more than 20 eggs. they did not behave as badly as the patients whom we did not do this. Of course, we were trying to do a well-matched, controlled, proper study, and we are trying to get more controls. But with the agonist protocol, which we are doing these days, the agonist trigger protocol, which we're doing, it is tough to get a good match control. So I'm presenting 3 cases which we did. The post-op, post aspiration of the eggs, we did the aspiration of the pouch of Douglas, and this how we saw what were the results. So after the aspiration, we know that the angiogenic factors and the VEGF would reduce in the pouch, and maybe it will help us have better results in these patients. So in addition to this, I would also add that, in addition to taking out the fluid from the pouch of Douglas, I would also make sure that none of the follicles are carrying too much of fluid, residual fluid in them. I mean, this is not a very great information. I'm sure all of you are emptying the follicles completely, especially in the patients of PCOS. But if in just in case you've got the egg and you feel that, okay, fine, you can leave some fluid, make it a habit to completely empty the follicles, especially in cases of PCOS. So in addition to the pouch of Douglas aspiration, I would make sure that all the eggs are completely bereft of the fluid, so that we reduce the theca cells and the fluid made by the theca cells, which is angiogenic and vascular endothelial factor rich, staying in the follicle and exacerbating the syndrome. So what results I saw in the patients, we saw that, in these 3 patients, the antral follicle count in the first 2 patients was 15, and the third patient was 30. And the anti-Mullerian hormone was, around 4 to 5 in the first 2 patients, but it was 21 in the third patient. And the protocols which we used were the long protocols for the first 2 patients and the antagonist protocol in the third one. And the pre-trigger values were very high, and they were like 7,800, 6,860, and 8,800. So we use the trigger. What I'm trying to tell you here is that we use the trigger of recombinant HCG for the first 2 patients. And of course, we knew that the third patient is having even more number of eggs in spite of using the antagonist protocol. So, this is also to tell that antagonist protocol is no guarantee that you will not have, patients or PCOS going into OHSS. That will eventually happen even with antagonists if the patient is having such high AMH. 21 is, 21 is the report which is actually given as something like this. They would write as more than 21, because beyond that, the AMH representation is not there in the reports of the labs. So in this, we would expect that the patient would go into HSS, and the severe type was looming on our minds. So we use the agonist trigger, and we saw that in all these patients, I had done the pouch of Douglas aspiration. And these were the 3 patients which we tried all the other tricks which we have mentioned, like giving cabergoline and albumin and starch, and giving letrozole tablets. So we saw that the oocytes which we retrieved in these were 37, 47, and 20. And the posterior ovarian size, which we saw, was not very huge. They were coming less than 8 centimeters. It's, 8 to 12, then goes into the severe mode, isn't it? So the size of the ovary after the aspiration on the first 3-4 days, we saw was 6 by 6 in the first one, 7 by 7 in the second one, and 7.7 and 7 in the third one. And these ovaries were not increasing more than this, because sometimes we have seen that most of these patients will be having these small residual follicles will start growing, and the ovaries become huge, sometimes more than 12, 14 centimeters, sometimes like small mini footballs in the abdomen. So that I did not see in this patient. And post-op, the abdominal free fluid was minimal in the first 2 patients and mild in the third patient. Mild in the sense because I saw some fluid beyond the pouch of Douglas in the pelvis, but not in the abdomen. There was minimal interloop collection, but then it was not enough to reach the Morrison's pouch. So the fluid accumulation was very less, and the pain severity was from mild to moderate, and the patient was not having so much of pain that I felt like admitting them to the hospital. And they were managed by a paracetamol tablet most of the times. And one patient required an injectable tramadol once, but then that was on outpatient basis. And abdominal distension was also mild to moderate. and none of them had any respiratory distress, and none of them required any assistance. Where I thought that the respiratory distress, the fluid accumulation is so much that I must do a tap, because the fluid was barely beyond the pouch of Douglas and barely beyond the pelvis in the third case. And I'm not mentioning all the laboratory reports, because it's a trend where we want to just reduce the number of the amount of information which is normal. I don't want to mention that in the slide here. It's too voluminous a slide as it is. So the KFT and the LFT and the hematocrit were all within normal limits. The hematocrit, which was highest, was for the third patient. It went only as high as 35. So it was not even reaching up to 45, which was the criteria for saying it's a severe ovarian hyperstimulation syndrome. And what is the best thing which I saw in these patients was that none of them required any tapping, because I was not confronted with a abdominal distension which was causing any discomfort to the patient. Of course, all of you know that we can do the tapping through a transabdominal route and also from the transvaginal route. I have done the transvaginal route a number of times, and some of the time we'll discuss that how many things I can use the transvaginal route to aspirate so many cysts and so many collections, and trying to avoid laparotomies. But then that's in some other forum, some other topic, we can discuss that. But yes, tapping was not required for this patient at all. So I was very relieved that that was the only thing which we did different from all the other patients which were undergoing various different type of protocols and having so many other tricks of trade of reducing the ovarian hyperstimulation syndrome. We are using all of them in all these patients who have PCOS and more than 20 eggs. But this was the only thing which we did different. And we saw that these 3 patients did extremely well, as compared to the ones who had severe type of ovarian hyperstimulation syndrome. So what was not required was that we did not have to do any tapping, or none of these patients required any admission to the hospital or ICU care. So this is what I was trying to tell you, that probably, I would come with a case control kind of a study. And what we have done is that we've taken these case reports and I've already applied for a publication in one journal, international journal. Let's see what directions they give us and how we can grow from here and get a good case control type of study and present in a better way. But then this is what I've seen, and maybe some of you can also start working on this and we can compare our results. All right, and thank you so much for this patient listening. I hope I was not too fast in my diction and in my dictation here, but I hope all of you got the point of doing this Pouch Douglas aspiration whenever you get the opportunity. Thank you so much.
Thank you very much, sir. I request Dr. Kritika to take over. Participants, please, if you have any queries, you can send your queries in the chat box.
Dr. President, it was a very crisp, to the point presentation, and you have taken a very practical point and elaborated on it. So what I would like to know is, what was the amount of fluid that you had aspirated in these 3 patients?
Yeah, actually, what happened that the slide was getting so bulky that I did not write that part. So it was 70, 75, and 100 in that order: 70, 75, and 100 ml in these patients. And that's a lot of fluid after doing the pouch, doing the aspiration, doing the TVOR. And if you have that much of fluid in the pouch, I thought that is an irritant more than anything. When we were trying to do the emptying of the pouch of Douglas, I was trying to reduce the irritation more than anything else. And the result of having a better post-op period and having less OHSs was actually, I stumbled upon that more than anything else.
It's a very a practical point that you're suggesting, and because all of us are scared of OHSs, and anything different, anything additional will always help us. And one more thing, what I wanted to ask is, you're talking about prevention in this aspect to prevent a patient going into severe OHSs, which may require paracentesis. But what I want to understand is, can we extrapolate it to patients who have had ascites, who are having ascites, who are suffering from severe OHSs, instead of abdominal paracentesis? What is your view about doing a transvaginal aspiration?
Transvaginal aspirate is, there are 2 things about aspiration of the ascites. One is that one is the root, and second is the amount. And all of us know that there is these patients are not actually sick patients with liver disorders or anything else because of which they have ascites. Then there's no pathology, comorbid pathology which is causing the ascites. It is a fresh insult because of the stimulation which we given. So these patients actually don't do too bad if we aspirate all the fluid. So when we're doing a trans-abdominal aspiration, when we're putting the needle on the flank and blind, we do it blind sometimes because it's too tense and we know that we will get the tap easily. But then most of the times we're doing under ultrasound guidance. So when you're placing the needle, you know that you could get 2 liters to 6 liters easily. And sometimes when beyond 3 to 4 liters, you have to change the position of the patient and you have to make sure that you're not entering bowel and you're not, getting some blood in the tap. So what is the best thing about a transvaginal aspirate? That I give a little head up and I have all the fluid accumulated in the pouch and there is just one needle and we are slowly aspirating it. And that is a complete aspirate. And I've gone up to 6 to 7 liters aspiration and I've not seen any patient having any problem regarding the volume which I've taken out. If I've emptied the abdomen with the trans-abdominal or with the transvaginal aspirate route, I've not seen a patient going into a severe hyperproteinemia and developing a hypotension because of the sudden decompression of the abdomen. And we all in our post-graduation and also in our MBBS remember that if you suddenly decompress a ascites completely, we can have a patient going into all these complications. But none of these happen with OHSs because the patients are young and they are having no other disorder. So their tone of the blood vessels is actually very good and they compensate for the fluid decompression very well. So I would always say that the same equipment which you're using for the aspiration, you can use the cyst aspiration needle. Cook is providing us a 18-gauge cyst aspiration needle, which is a very good needle, and we can use the same with a 50 ml syringe, or we can attach an aspirator also. And it's a very good method of emptying the whole content without actually injuring the bowel or wondering that the exact amount of fluid has come out or not.
And any anesthesia? What is the anesthesia you recommend for these patients?
Actually, transvaginal aspirate, I just give for the purpose of aspirating. I will just give a local anesthesis into the vaginal vault before I aspirate. I would not give any sedative because most of these patients have a bulging pouch with the fluid. And I would, load the syringe with just 1 ml of lignocaine and then change the needle. Change the syringe and take a 50 ml syringe and aspirate it, completely empty the. Of course, it takes many number of, I've not used the pump for this because I feel that the pump should not be used. All of us have limitation of equipment in the hospital. So I don't want to use the pump for emptying, using the energy of the pump to empty an ascites. So I use the energy of my hand. So yes, it takes multiple times. You have to take out the syringe and, reattach. That's a practical problem, but it's all right. It's worth the effort, It's around 15 to 20.
Yeah. Dr. Prasan, I have a question. Like after the aspiration, do you follow the same protocol, like giving the cabergoline and the antagonist injections and everything to prevent further collection, or what is the follow-up of these patients immediately?
Dr. Indumati, this is a very good question, because that's what I was trying to tell in the beginning, that the basic tricks which all of us have, basic methods of reducing the severity and trying to avoid a complication like cabergoline, letrozole, albumin, starch, they weigh the same in all the patients, because the moment you see that you have 20 eggs at your hand, then we are getting a little worked up and we are worried about the OHSs coming up. Yeah. So yes, the basic protocols were the same. The only thing which I did different in some patients was emptying the pouch of Douglas, because I saw that there was a lot of fluid after the aspiration. Sometimes you feel we pricked a vessel. That's also one big thing on our heads, that you've gone through the uterine artery or you've gone through a descending cervical, because you feel that when you're going through those stuff behind the uterus follicles, when they are adhesions, so you're going through the uterus sometimes. I've gone multiple times to get those the follicles. So when you're going through them, you feel that you pricked a vessel, although not a major vessel. So those vessels keep bleeding. So I feel that if I am able to empty it and it's not refilling, that gives me a sense of, closure with this patient, that she's not bleeding anymore and there's no further collection. So that is also a factor playing on my mind, that once I took out all the fluid, it is thin blood, and it is coming out easily. It's not in clots, because if it is a fresh blood, it will clot up for some time. And if it is lying there during the duration of my aspiration, then it will mix with the fibrolytic factors of the peritoneal fluid, and it will be in fluid consistency. So when this fluid empties easily and no further collection comes, it also gives me a satisfaction that I've not gone through a vessel. So yes, I would have the basic protocols of OHSS prevention going. In addition to that, I've done this. So that's why I was thinking that maybe this is a little different. I'm just suggesting to the forum that maybe you can also try and tell me that how you saw your patients doing after doing this aspiration when they're 20 odd follicles and more.
Are you still doing this?
Yeah, I mean, fortunately, I'm not having so much of fluid collecting in these. That's why I said I've had 3 patients with a significant amount of pouch Douglas fluid. Of course, whenever I see this, the control would require me to see a patient with so much of fluid inside the pouch and not aspirate it. So that's where I'm stuck a little bit to get a good paper out of this, because if there is a patient with 100 ml of fluid in the pouch and I don't aspirate it, I would feel that she's going to have this OHSS, and just because she's in the control arm of the study and I leave her, then maybe she'll not do so well. So that is what is binding me. So I'm going to get a suggestion from my, people who are doing better studies, and we're going to do this in a different way. I must present this data. So far, I'm just presenting this as a suggestion to the journal which I've applied, so that more people try this and come out with good methods of doing a controlled study.
Over to Dr. Kritika for the other people who have the doubts.
Yeah.
Somebody has asked a question which I saw popping up, that are we, by aspirating the follicles, did you mean dominant follicles? I mean, of course, even the intermediate follicles and even the small follicles, I would, I would not want them to grow up later. And if you take out the cells, if you take out the cells which are making the fluids, in the theca cells which are actually exhibiting the fluids, the angiogenic factors, if you reduce the follicular load of these cells, then these patients do better, rather than leaving these intermediate cells, because anyway, we're not going to do aspiration of these follicles later on. So might as well empty all the follicles as much as you can. And Dr. Kritika, you were asking me something. Kritika, you can hear me? Right. So I'll take the other questions which I saw.
Do you want me to read out the questions?
Yeah, I can see them, ma'am. With the header position, you have to be wary of bowel. Actually, with the header position, the bowel actually would float. You will never see bowel coming and the fluid staying up. We know fluid will be more easily coming into the dependent part of the pouch of Douglas. That's why I say, please use the transvaginal route for far more things. Dr. Paili, I remember, and of course, some of my teachers in JIPMA, Dr. Habib and Dr. Raghavan would tell us that we can do an ectopic pregnancy also going through the vaginal vault and taking out the tubes from the pouch of Douglas rather than opening their belly. So the vaginal route is, of course, easier, and I can see this on the transvaginal ultrasound much clearer. And even if there is bowel, I mean, like if there's an adhesion, like the doctor who's asked me this, even if there's an adhesion, I'm so sure that I can move my needle around easily and avoid the bowel and reach the site where there's a collection. But with this kind of ascites, you will not have a problem. Don't worry about entering bowel, not at all.
What is your opinion? What is your say on minimal stimulation protocols to avoid the whole situation?
Yes, of course, ma'am. That is catching the the tail from the other end. Of course, it is. That's where I'm sure the expert herself has asked me this question.
Because
ma'am, you're working so much on minimal stimulation that is, of course, the way of getting something between 3 to 6
Dr. Prasann, when I was doing the IVF work in 2015-16, we used to do tapping very frequently, and I have done many paracentesis, and then the technique which we used to talk about, the vaginal tapping also, I used to take around 4 to 5 liters in one single sitting, but nothing happened. But then do you have a control with whom you compared these patients?
Yeah, that's where I'm stuck. Like I confess that it's very difficult to get controls. You know, if you have a patient, see, if you have ascites in the patient already, I mean, she's post aspiration, post oocyte aspiration, day 4, day 5, and she already has ascites, then it's a different story, ma'am. I'm talking about the patients who are undergoing the transvaginal oocyte aspiration, and at that moment you have a patient who's got 100 ml of fluid. So I have been aspirating at least around 20, 30 patients. I've done the aspiration, and I'm presenting 3 big cases to you. But now, not aspirating the few patients who must become controls of my study, that is becoming a little tough for me to decide, because I have seen that the ones which we leave the fluid don't do too well in the post-op, immediate post-op at least. They have this tenesmus, abdominal pain, and distension is more in them. So for the need of not getting them into discomfort post-op, I eventually aspirate whenever I see this. So yes, that's where I'm stuck. I told you that I'm not getting
your observation was that this elevated the symptoms in the post-op period, or that reduced the progression to a severe OHS.
Both, ma'am. Both of these are my observations. That one is the primary objective was to reduce the post-op discomfort, ma'am. Like I told you earlier, I would want the patients to have a better post-op, and they should walk back home within 6 hours of the procedure. That's the motive. But I also saw that when they come for a daily follow-up for 4-5 days, since they had 20 odd eggs and more. So when they come, they have much lesser requirement of albumin, much lesser requirement of doing the daily tests of seeing the profiles of CBC and KFTs, because we generally used to do on a daily basis when we have more than 20, 30 eggs. But these patients, we saw that the reports are so good that we are doing it on alternate days, or doing it just once and then just doing a follow-up of the symptoms and doing it only when it is required. So both the objectives were in my mind. One was reduction of post-op complications, and 2, reducing the severity of OHSs.
You kindly let us know when you are publishing this.
Can I?
Yeah, I've already applied, ma'am. I've already applied as case reports. I've already applied as case reports, so that at least there is some information about this. And let's see, they'll be sending me their suggestions. And I'll be happy to show you the results of a controlled study, as and when I'm having the guts to leave this fluid inside and see what happens to them.
Okay.
Can I invite Dr. Radha Pandian to share her views? I saw a few questions that she has raised. It'd be better if she can interact directly.
You can't see me. Okay. Hello. Hello. Namaste. Vanakkam.
Vanakkam, ma'am.
So very nice. I have posted some chat questions because I found that this original idea is interesting.
Yeah, I saw that. When I read that, I saw your question, ma'am, and I was trying to ignore it as much as possible. But then
sorry.
I was like, ma'am, I thought you wrote the question and you went back for having your dinner, but you're still here, ma'am. So,
this is,
ma'am, what happens that
I'm in the USA very much before noon in the morning.
It's noon for you. Yeah. So you are up and awake.
It's okay.
And, yes.
It's fine.
And you
I'm
are
enjoying.
at the peak moment of your day. Kritika, it's a little unfair to have these fresh people with fresh ideas.
I'm so
yes,
glad.
ma'am. I would. Yes.
I posted a thing because its observation is usually later part of it that the collection happens. It's not an immediate post-operative, because I'm glad your patients did well. I'm glad you reduced their symptoms and the progression didn't happen and all that. But invariably, the cases you presented were all really high-risk cases, especially the third case was astounding. I was just thinking and you were left with only 27 oocytes. So I was thinking the way our AMH and the number of antral follicles were, I was just thinking about it. And then I thought, usually it happens later. That's what we have seen. It happens later. It's not that immediate thing. Maybe, as you said, because
so that's where I was. trying to
Not-
when you said this, that it's a transit rate and not a puncture. So I'm talking about the immediate post-op period, ma'am. I have done the aspiration of the oocytes, and I've just finished the procedure, and I'm still with the same anesthesia, and I see this Paucho Douglas collection. So this is immediate, ma'am. So the transit route won't come so immediately. That's why I was trying not to answer this.
That's why I said it's a later phenomenon.
Yeah.
Later phenomenon due
So
to
the
transit,
ascites, of course, the ascites which we see and all that which we are confronted with, the abdominal distension, that is a later phenomena. So immediate collection of fluid post-op, I would feel, is because of the surgical bleed and the fluid coming out from these follicles and the leak. That's what I was thinking, because to have the transit rate happening, it'll take more time. It'll take at least 24 hours and more to start presenting as collection.
I agree, because these ovaries are grossly enlarged and you see the follicles popping up and you're trying to aspirate all sorts of follicles. There will be a little blood. It's not a dense hemorrhagic fluid. It's a mildly blood stain, but then you minimize the punctures. See, as we train people, we have the number of punctures we go through are very few. We don't do so many. And you said the number of oocytes, a number of punctures tally and all that. It's not that so many punctures we are making. It's a
It's
minimal
not on the ovaries, ma'am. Ma'am, okay, fine. You know what happens, ma'am? All of us, when we are having this, the number of cases which you do over the years, and suppose, 2003 onwards, I'm doing aspirations. So yes, the punches in the vagina, one for the right ovary, one for the left ovary, and punch in the ovary, till your needle is blocked, don't take out. The basic principle is then from one puncture, try to get as many follicles as possible. But the process of puncturing the follicles in the periphery, the follicles which are on the surface of the ovary, that won't change. So when you're doing those punctures, of course, we are trying to go from within the ovary to these follicles. I feel that somehow they leak into because else why would a person like me who's done so many cases, of course, I'm also into the teaching and I have fellowship students with me. So I would, want my fellows also not to have so many punches in the ovary and increase the risks of, bleeding, simple post-op bleeding to increase. So yes, that is there. It's playing on my mind, ma'am, that I should not have too many punches. But since I saw this happening so many times, and I thought the patients are having so much of collection in the post-op period, and they are having this tenesmus kind of presentation, and they are like, they keep on saying that I want to go to the loo, I want to pass urine, and I feel like passing stools, and that's basically because of the collection. So I thought, okay, next time onwards, I'm going to empty everything. So that's where I thought maybe in spite of reducing the punches in the ovary, you do find some of them seeping in, causing, and ma'am, we all know that we try to go with just one punch into one ovary.
Even the aspirated follicles, they don't collapse. You see that you do another scanning after some days.
Yeah, they will come back. They will come back. They will come back. But then, we have taken out the cells. We have emptied the cells, ma'am. The cells which are producing the angiogenic factors, ma'am. So those cells, once they are emptied, then I feel the severity is lesser. Yes, we have seen the follicles. Day 3, the ovary is still having so many follicles, and all of us see that.
And if you have
FSH
the
is still
habit
acting.
of flushing, then that will also cause more of collection and all that. If you don't flush, with these grossly enlarged ovaries, then you may limit.
We won't flush for PCOS, ma'am. I mean, we would flush. I would do flushing for all these patients who are having only 4 or 5 eggs. Yes, those things keep happening when we are desperate and there are 3 or 4 follicles. Those we would flush, ma'am. These generally PCOS flushing means that's a bad day at work, ma'am.
I agree with you. Anyway, this concept is your original idea. I appreciate it. But then, I mean, I'll have to think about it and think more about it.
Yeah, please give me. I'm available at Kritika knows. She was my classmate. She knows all my details, and I'll share my email with you also, ma'am. Whatever ideas you get, I'll be the happiest to use them into my project and into my next presentation, ma'am.
Okay. And then another dictum is minimal stimulation, as Indumati pointed out. All these cases, minimal stimulation, take it as a thing, as a policy, so that it will be a minimal amount of follicles coming up for a thing, and so that's will be the best thing.
Okay.
Okay.
Thank you, ma'am.
Okay.
Because there were
Thank you.
too many questions, I thought instead of me asking.
I'm sorry. I didn't want, I just posted them. I thought he can see as he felt rightly. If he can choose to ignore, he can ignore. So
Thank you, ma'am.
okay.
Thank you very much.
Bye. Thank you.
Yeah. And
Thank you so much,
sir,
ma'am.
Professor
Thank you.
Pandyan, do you want to just add few lines, sir, your opinion, and we'll end the session.
How much time do I have?
So you have all the time. You can take.
Sure. No, I don't want.
Take the time.
Prasanna, you give a wonderful talk. Wonderful thought and a wonderful talk. Wonderful thought and a wonderful talk. I think the message is prevention is better than cure. And I think you are trying to say that by aspirating, you can prevent OHS happening. Thought, really good thought. We all know blood is an irritant for sure. In fact, as you rightly pointed out, if you look at the cul-de-sac, you probably don't look at cul-de-sac now these days because with an ultrasound. Those earlier era, I've been practicing from 85. It used to be GIFT those days. GIFT was supposed to be better than IVR, so we did a lot of GIFT in those days. And when you put a scope inside, you see such a mess inside. When you do aspiration, no matter how good you are, you're still puncturing an hyperemic ovary. So as you rightly pointed out, it bleeds. It bleeds, there is fluid there, there's a lot of fluid there. So I think aspirating is a good thought, wonderful thought. Only thing is, I think you have to package it in such a nice way that you're able to publish it. All you need to say is probably a pilot study, saying that a pilot study. And the point you need to raise is it now unethical to stop aspirating? Because you are there. Because when you raise the point, people will be thinking twice. Should we, when you are there, the patient is under anesthesia, and you already aspirated the follicle, there is a lot of fluid collected there. How can you leave it and come? So if you raise that point, I think more people will start attempting to aspirate. And if the incidents, the best way to compare would be the previous era. The era before when you are not aspirating and the era you are aspirating now. And that will give you, to do a study is difficult. I would think it's even unethical. If you think this is working, how can you justify leaving 100 ml of fluid inside? So I think that's a wonderful thought. One out of the point you just want to raise is just food for thought. We all keep saying that VEGF is probably the contributing factor. If it is so, VEGF is also contributory in tumorigenesis. Are we in some way inadvertently raising the risk for these patients? I'm talking about OHS as such. As Indumati beautifully said, the best is to prevent OHSs. Not happen at all. Go for a softer stimulation, but softer stimulation is not going to happen overnight. Barring that, I just a thought, just to add confusion to the existing scenario. Just think about it. You're a long innings to go, whether these patients are a high-risk candidate for tumorigenesis. Otherwise, wonderful talk, wonderful thought. Hope to see you as a publication soon. Congratulations and all the best.
Thanks so much. I appreciate your kind feedback, sir. Thanks so much.
Thanks, President. IFReF's main idea is encouraging original work, and that's what we want. And it's wonderful presentation from you. So over to Dr. Pavitra to give the vote of thanks. And if there are no further discussion, Dr. Indumati, anything else you want to add?
No, nothing. I think you should continue to do your bold job so that you will have more cases to, and then have a good publication work. It will help. And give a thought about what I was telling about the minimal stimulation also. Sometimes I feel it's not worth the trouble for both of us, the patient as well as us. So, I mean, it's just a thought.
Definitely, ma'am. It's definitely very much in vogue kind of a principle. We know we've been talking about minimal stimulation for the last 5-10 years.
I just
the protocols are so much in place now. So rather than facing too many eggs, it's just that the finances sometimes trouble us to decide whether to try to get 4-5 eggs or try to get more eggs in one and go for a frozen embryo transfer and have a bank balance kind of a situation for this patient. So that's where it evens out for the time being. I hope
it's almost like an investment for them, isn't it? It's like a financial investment for them. So you want to take the best out of the first chance. So that's the whole thing.
Yeah, because all these 3 patients have children now. I mean, this is around more than a year back where I had these patients. But then I was trying to get a control, and I did not have the guts to, like Dr. Pandian so rightfully understood my, my, my dismay of trying to do and not to do. It was almost like he said, it would be unethical when I know that it's going to cause a problem. So because of that, I was not presenting them, but now I said, okay, fine, let this go as a pilot study, at least let it go as case reports at least, and see how we can build on that.
Yeah.
Thank you, President, for accepting the invitation. And amidst all the pandemic and all the problems, you have taken your time out for this. Thank you very much. And now I request Dr. Pavitra to give you a vote of thanks, and we'll end the session.
Thank you very much, Dr. Prasann. As the chairpersons and Professor Pandian and Dr. Radha said, it was a great topic, and you had given an elaborate details along with data. So that is what we've always wanted in IFReF. Thank you very much for that. And I thank the chairpersons, Dr. Indumati and Dr. Kritika Devi, for the wonderful discussions. Professor Pandian and Dr. Radha Pandian too, and all the attendees for the day. Thank you for joining. And I would also like to thank Sun Pharma Senora Division, Ms. Rashmi, Mr. Sapan Shah, and Mr. Balaji and Ranjit, who've been helping us to organize this CME program every month. So thank you all. We take care and stay safe. And we'll meet you all in the next CME program next month. Thank you.
Thank you. Thank you all.
Thank you.
Dr. Prasann.
Thanks so much. And good evening, everybody. And good afternoon, ma'am, Dr. Radha.
Okay. Thank you. Thank you.
Bye-bye. God bless. Stay
Thank
safe,
you.
everybody.
Thank you.
Bye-bye.
Thank you.
Bye.
All the best. Good luck. Good luck for further work. Bye.
Thank you, ma'am. Thank you.